Yes. Good evening, friends. This is it's another meeting of our Interventional Nephrology Forum, which happens every last Saturday of the month, 8 o'clock in the night. And this time, our theme is on peritoneal dialysis. After an initial session, when we had formal, regular, simple introduction of PD catheter demonstrated, after that, we didn't talk much about PD. And this time, we are going to discuss about the complications of PD catheter and misplacement and things like that. We may not be covering everything. And let me welcome the chairpersons actually who are joining us for the first time, Professor Amit Gupta and Dr. K.S. Nayak. Both of them are in the CAPD scene in India. I think they are great luminaries, and they have done human service for development of CAPD in our country. Besides Dr. Georgie and Professor Amit Gupta. Uh, yeah, I'll start with Nayak. Dr. Nayak had his nephrology training in Apollo, and after that, he joined Apollo as a consultant, then moved on to Hyderabad. And right now, he's the chief nephrologist in Virinchi Hospital. And, he specializes in peritoneal dialysis and renal transplant and ICU nephrology. And his academic activities are really, I am amazed, in a private setup, the way he gets interested in out of the way things like telemedicine and home PD and things like that. And even now he's trying to innovate in the fluid section, and he keeps, even at this late in the career, he keeps pushing himself for the goodness of CIPD. And he has been member and administrator of numerous societies in nephrology, PDSI and Asian chapter and ISPD and so on. And he has successfully conducted many international congresses in CIPD. And I think the few names, international people in CIPD society would know are Georgie, Amit, and Dr. Nayak, and I'm glad he is with us today. And Professor Amit Gupta, who has just retired as director and HOD of nephrology in SGPI Chandigarh, Pune, Lucknow, and right now he is attached to Apollo Medics Super Specialty Hospital in Lucknow. And again, his CAPD is very close to his heart. And after his nephrology training, he had his fellowship in nephrology in Guy's Hospital, London, and he had a stint of training in Toronto, the mecca of CAPD. I think that is where his passion for CAPD started. And he was past president of Indian Society of Nephrology and past president of PDSA. And I, got associated with him as treasurer of PDSA for quite a long time. And now periodically I meet him as examiner for MRCP in Chennai. He has very many publications, and he has authored many chapters and books. And welcome, sir. So let me finish introducing the speakers also. After that, we'll jump into the forum as such. Dr. Adrian is very well familiar to our audience. I think he has become part of the the organizing team for Inform. He's basically from Bangalore. Just now he was discussing, he had his undergraduation in St. John's, Bangalore, and MD in Kasturba Medical College, Manipal. Then later he moved to US and did his residency in internal medicine, followed by fellowship in nephrology, and he is now in Shreveport, USA. And he was trained in fellowship in nephrology, interventional nephrology, and right now he is holding important post in ASDIN. And last meeting we had him as the guest of honor, and today he is going to tell us some of the complications of PD catheter insertion along with the other two speakers. Welcome, Adrian. And the other presentation will be from Dr. Ram's team. Dr. Ram is professor and head of nephrology, and he is a medical superintendent of SWIMS Tirupati. And I was, pretty associated with him as treasurer of IS in Southern Chapter, where he became treasurer, secretary later. Then he was heading PD Society of India, and he has a very large PD program in his hospital. And his institution is getting very popular as a good center for DM training. And today he is letting his PG Aishwarya present the cases. Welcome Ram and Aishwarya. And Dr. Manas Ranjan Patel, he is from SGPA. And I, thought of him especially because a recent publication from him and his team is on a particular complication of PD, namely pleural effusion. And so hearing it from the horse's mouth will be great. And I'm sure Narayan Prasad also will be joining. And he is still attached to SGPA, and he has more than 15 publications in Indian and international journals, and he has authored chapters and ebooks, and he has done many presentations in national conferences, and he is a reviewer of more than 4 journals. So I welcome all the speakers, the chairpersons and the delegates who have joined, and I'll stop sharing my slides. And I invite Dr. Amit sir and Nayak to talk to the people who have joined about how they got into CAPD and their message for the beginners and the juniors. Dr. Amit, you can give your impressions on your experience in CAPD as such.
Okay. Is my screen visible?
Yes.
Okay.
Make slideshow, it will become bigger.
So I'll just speak a few words about peritoneal dialysis, a little bit about the history of dialysis, peritoneal dialysis.
Amit, it has to be put on slideshow, the full screen.
It's not on slideshow?
No,
it's on standard show.
Maybe...
So you have to go to slide. You have to go to that small icon right below.
Yes.
Yeah, that one. Yeah.
Is that okay?
No, not yet.
Not yet.
Okay, maybe I'll continue like this. There's some problem.
Okay.
So peritoneal dialysis is less widely available than hemodialysis, although in many countries PD is the first modality of dialysis therapy. And this photograph is that of Robert Popovich and Jack Moncrief, who introduced peritoneal dialysis as a form of therapy for one of their patients who ran out of vascular access.
You can advance.
So Jack Moncrief was the nephrologist, and Robert Popovich was the physicist. Popovich was a great friend of Moncrief, and Moncrief discussed this patient who had run out of vascular accesses. And then Popovich told him that if you do 5 exchanges and with a dwell time of about 4 to 5 hours on each exchange, you'll be able to reach a steady state of equilibrium. So they kept this patient going for a few months until he received a transplant. And it was then Dimitrios Oriopoulos from Toronto in Canada who actually popularized peritoneal dialysis and making it ambulatory by using plastic bags which could be folded and kept in the pocket of the patient. And there have been several innovations in the technology of doing peritoneal dialysis in terms of the catheters as well as the PD bags. And now we are using something known as a twin bag, where you have a single connection, and as a result of using this twin bag, the peritonitis rates have come down. At our own institute, The first patient that we started on peritoneal dialysis was way back in October 1993. And we used this O-set, uh, which was the O-set you had to fill in with amokina, which was actually sodium hypochlorite solution, and then keep it till you do the next exchange. Very often, many patients would forget to drain out the amokina before they would connect the fluid bag, this bag, and therefore many times they will get severe pain in the abdomen because the amokina would cause chemical peritonitis. Now, unfortunately, peritoneal dialysis is yet to take off in a big way in India because many people think that it is associated with inferior survival and there are more infections. But it has been seen that the mortality rates during the first year of therapy and subsequently have greatly reduced in peritoneal dialysis compared to hemodialysis. And there have been several reports from various registries with the USRDS or the Canadian study or the Spanish data from Korea, which have shown that almost similar survival with patients of peritoneal dialysis and hemodialysis. And the incidence of peritonitis also has greatly reduced with peritoneal dialysis over the last decade. At our own center, the incidence of peritonitis has come down to one episode every 5 years or so. Even in terms of quality of life related issues, when they compared PD with hemodialysis, most of the studies have looked at the three domains, that's the physical domain, the psychological domain, and the general domains, and have also found that there is PD scores better over hemodialysis, though not significantly. Now, the key to a successful chronic PD program is permanent and safe access to the peritoneal cavity. And the catheter-related problems, as the three speakers will inform you, is the second most common reason for transfer of PD patients from PD to hemodialysis. And it's been seen in the first year, almost 12% of patients who start treatment with PD, they transfer to hemodialysis. So what should be an ideal catheter like? The ideal catheter should be durable. It should be be an effective barrier against infectious agents, have good biocompatibility, should not leak, should not become displaced, it's safe and effective in placement by all techniques, and rapid rate of dialysis flow. So with that, I'll stop and I'll ask Professor Nayak to say a few words, and then we can have this session forwards.
Thank you, Amit. I don't have slides. I think the slides will be the three speakers following will highlight each aspect of exactly what Amit said, the catheter-related issues. I'm very. I think the main thing I should convey to you is this initiative by Dr. Balasubramaniam is doing a wonderful job, and today is the day when he's focusing on catheter-related infections. The problem in India, one of the important problems, as Professor Amit highlighted, the second commonest cause is the PD catheter-related issues. But the problem mainly in India is why the numbers are not going up, because I can, with my past experience, tell you that there was a time in 2004 when the number of PD patients in China and in India were the same. We had about 500 patients on PD in India, 500 patients on PD in China. We are still about, I would say, 6,000 to 7,000 patients on PD in India. And the PD in China is now the highest in the world, has crossed much more than 1,20,000 now. 1,20,000 patients on PD in China. They have a center in Guangzhou with satellite centers, which has more than close to 3,000 patients on PD. So half the country of India is undergoing PD in Guangzhou and surrounding areas. What happens is when these kind of problems, mechanical issues, which we are focusing today, we're not talking about metabolic issues and other issues. There is no concerted effort by the nephrologist or the PD team to act quickly and remedy the situation. So we are having a classical situation of a frog jumping out of the well where it jumps out and comes up 2 steps and slips down 3 steps. So we are doing probably a good number of initiations on PD, but we are not doing maintaining them. The PD vintage is very low, and also dropout rate is very high, and the quickness with which a patient is shifted from PD to hemodialysis is something which they haven't been really given a good trial of or proper counseling when there is a PD complication. So I'm very happy that Subramaniam, Dr. Balasubramaniam is focusing on these important issues so that we don't have a patient that drops out. And I'm very sure, and I hope at least, that the 3 speakers are going to give examples of how they surmounted the hurdles of PD, the catheter-related problems that they had, and how they successfully continued the patient on PD. So thank you very much, Balasubramanian, for the PD community in India. And I hope the students here learn more and more on PD. About 10 years back, I myself remember speaking at the ISN and requesting the DNB and the DM examiners to compulsorily put a PD patient for the clinical case and put questions on PD in the theory, so that it's a incentive for students to know more about PD. So thank you, Balasubramanian. Let's proceed with the.
Thank you, Dr. Amit and Dr. Naik.